So I welcome you all to this conference and this session. Over to you all for the discussions as well as the presentations. We can start the first presentation now.
Arup, would you please move on?
Good evening, friends. I will start off with a disclaimer that my worst case scenario in the context of a biometric error has not been my field of expertise for quite some time now. In fact, how can it be today when cataract surgery is a refractive procedure and the emphasis is on hitting the bullseye in all our patients, offering them a reduced spectacle dependence. So majority of the poster patients are very close to the refractive target with minimal prediction error. However, I have been able to pull out an old case who continues to visit me till this year. And that is my refractive surprise for the year 2021. Was I audible?
Yes, you
okay.
can hear you well.
Okay, so this is the story of a 76-year-old male patient who is an IFIS candidate because of his treatment for BPH and primary open-angle glaucoma, asking for cataract surgery in his left eye, which has a grade 4 nuclear sclerosis and 6/6 vision. The fellow eye was already pseudophakic with a vision of 6/6, -1 sphere and -1 cylinder. So the cataract surgery went off uneventfully, and I implanted a Technis acrylic 3-piece intraocular lens in the capsular bag. The post-op refraction was 6/6 at N6. However, there was a refractive surprise of -5.5 diopter sphere and -1.5 diopter cylinder with a spherical equivalent of -6.25 diopter. So he was having diplopia because of the anisoconia due to the full correction. So we undercorrected him. He was not very happy. However, his post-operative pressure, intraocular pressure was well controlled. And so we had to do some active intervention for him. So as part of treatment of refractive surprise, there are 3 options basically: laser vision correction, piggyback intraocular lens, and intraocular lens exchange. Now, laser vision correction is best except in cases of high sphere, and we are dealing with a high sphere, high refractive surprise, so that is ruled out. Intraocular lens exchange is one of the options, but it includes a lot of intraocular manipulations, and that may be associated with the intraoperative complications with posterior capsular and vitreous disturbance. There could still be a risk of incorrect intraocular lens power. A proper conduct of this technique, Iol exchange, requires a lot of instrumentation. So I decided to use a piggyback lens for this particular patient because piggyback lens offers certain advantages. It offers better patient satisfaction than corrective contact lens or spectacles, which do not work out in our patient. It avoids induced aberration and other risks associated with LASIK or PRK. And there is a less risk of incorrect IOL power and all the complications which I have enumerated, which may be associated with IOL exchange. So I decided to go for a Rayner Sulcoflex lens. This lens is a wonderful design, basically a 6.5 millimeter optic size, 14 millimeter overall length, undulating haptic. It is a meniscus design, rounded edge, so it sits very well comfortably in the ciliary sulcus. So this was my plan, and this is available in power range from -10 to +10 diopter. So I calculated the Sulcoflex power for this patient using the ray trace software of the Rayner online calculator, and it came to about -8 diopters. So I communicated that to the patient, and the patient was not willing for surgery immediately. So just in case, if you don't want to use a Sulcoflex lens, there are other options, and you can use the Barrett RX formula, freely available at the APS-CADS website, AS-CADS website. This formula can handle IOL exchange between 2 different IOL modules. Then, of course, we have the refractive virgins formula from Warden Hill's website. And for piggyback lens, if you don't want the Sulcoflex, then you can apply a simple rule of thumb, provided the postoperative emmetropy is within ±7 diopters and you are desiring a refractive target of plano. So if you have a hypermetropic surprise, the piggyback power can be determined by multiplying the spherical equivalent by a factor of 1.5. And for a myopic surprise, it is obtained by multiplying the spherical equivalent by a factor of 1.3. Refractive virgins formulas are also there on Warren Hill's website, free. So now this patient returned for surgery 17 months after the initial surgery. And it was a scarred corneal incision. So I went for a fresh scleral tunnel. Manipulations are required within the anterior chamber. So it is important that you protect the corneal endothelium with a good quality dispersive OVD. The lens is going into the sulcus. So if there is any posterior synechiae, that has to be lysed. I do not perform peripheral iridectomy, but I know some surgeons who do peripheral iridectomy for these cases. And OVD removal has to be meticulous because this is a glaucoma patient and I do not want any postoperative intraocular pressure spike. So a piggyback lens requires a primary lens which is quite healthy for the lens to sit on its back. This lens was the primary lens was little decentered because of capsular back contracture, but it has been there for 17 months. So I decided that, it's quite a steady support that the sulcoplex lens is going to have. And it was very well centered as you see here. And this is the post-op picture. Till this year, the patient is doing extremely well as far as the vision is concerned, with a little bit of pigment dispersion that you see here. So basically, using a piggyback lens, I have avoided most of the complications that we get with Iol exchange. However, we have to keep in mind and be alert to the possibility of inflammation, pigment dispersion, or ocular hypertension in the long run, which has not happened in our patient. So what went wrong? Why the refractive surprise? Well, this was a total cataract, very advanced cataract rather, and optical biometry was not possible. So my optometrist performed a contact ultrasound biometry. Obviously, that was messed up. So I was wiser from this experience, and subsequently, I have been using a very efficient and useful strategy while dealing with monocular hard cataracts. This strategy doesn't work for bilateral hard cataract. Now, this is the fellow eye, and the fellow eye needs to be pseudophakic or with very minimal lens changes. So I asked the optometrist to perform a careful optical biometry and ultrasound biometry, and there is good agreement between these two values. Then it is reasonable to assume that the optometric has used the proper technique, and whatever ultrasound biometry value I'm getting for the right eye, for the advanced cataract eye, is reliable. This is again confirmed by repeating the test once again, and this has done extremely well. And another thing I believe in is using the first eye prediction error to refine the refractive outcome of the second eye. So this works only when if you have a prediction error more than 0.5 diopter in the fellow eye, there has to be an interocular symmetry, transcription errors in terms of Iol power, wrong Iol power, etc. have to be excluded, and they should not be in Iol malposition. So it was basically like this. Instead of using the entire refractive, the prediction error to adjust the power of the next eye for the fellow eye to be operated, for the Barrett Universal 2, an adjustment coefficient of 30% is applied. And for the traditional older formulas, a adjustment factor of 50%, a 0.5 is applied. So let me just explain. Supposing if we have a prediction error of +2 diopter in the first operated eye, so I would not be taking track on the entire +2 diopters, rather 50% of that if I use Harford-Key, Holiday 1 or the Circuit T. So my target refraction will be -1 diopter. And so that if I'm designing for a eventual plano outcome for this patient. So this strategy has helped me in many of my cases where there has not been desirable refractive outcome in the fellow eye. So friends, in conclusion, refractive surprise or problems associated with refractive surprise can be avoided by proper counseling, by proper management of the ocular surface status, ocular surface disease, perform keratometry on the virgin cornea, perform optical biometry, ensuring that all the validation criteria are employed, repeat the measurements whenever called for, use the newer formulas, Barrett Universal 2 or Hill RBF, which I routinely use, respect the contraindications for premium channel intraocular lenses. I use a fixed site for my clear corneal incision, 180 degree for the right eye and 30 degrees for the left eye, and use a centroid value. Ensure that there is a rexis overlap on the optic, and use a reliable, predictable intraocular lens. I'm sure with these guidelines, your incidence of refractive surprise will come down drastically as it has happened in my own surgical experience. Thank you very much for your attention.
Thank you very much, Arup. That was excellent. I think in a nutshell, you have conveyed. Vasavada, sir?
Dr. Arup, what do you think was basically went wrong in this case?
Sir, it was the ultrasound biometry was performed by my optometrist. It was a very advanced eye. Optical biometry, advanced cataracts, optical biometry could not be done. And the standard error, the axial length was underestimated and the myopic
What was the biometry of the other eye? Did you compare with the other eye?
The fellow eye was, -1 sphere and -1 cylinder.
No, biometry of whenever you are not able to do the optical biometry.
No, it was within normal range. It was within the standard range. It was not a short eye. It was not the extremes of axial length. It was within the normal range.
So what do you feel? I mean, did you see the anterior chamber depth? Because most of the time, whenever the optometrists are doing optometry, if the anterior chamber depth is less than the other eye, then maybe he has pressed the cornea a little more.
Yeah, it was messed up actually. Yeah, it could have been prevented by careful ultrasonic biometry, but it happened. That is the reason I got a surprise.
Because comparing the biometry of the other eye and particularly anterior chamber depth becomes very, very crucial. And anterior chamber depth can be found out by various other methods as well. So if there's too much of a difference between the biometry of the two eyes, we need to really look into the anterior chamber depth, which can vary. And of course, whether the biometry was done accidentally at the macular area or not, which can add another error into it. So why, I mean, what was the difficulty in doing the IOL exchange? Because the IOL comes out very easily and comfortably even after many years of surgery.
Yeah, so let me tell you, sir, what happened in this particular case. He was quite happy with the fellow eye. First I operated. Second, I had a huge spherical equivalent of almost 6.25 diopters. And he was an IFES candidate. He was an elderly man, small pupil. And it took me some time to convince him that, we will require definitely surgical procedure. Glasses were given as anisectomia, diplopia. He was not happy, so I had to undercorrect him. So it took him 17 months to come back to me for the surgery. So by that time, the lens was slightly decentered, though it was stationary, and it would have been a difficult task for me to try to exchange the lens. So I thought Sulcoflex was a good option in this case.
So good surgery overall, excellent management. Any other?
Thank you very much. Thank you, Arup. Actually, Sulcoflex is really a big savior when it comes to these situations, and it works extremely well. Little expensive, the Sulcoflex lenses, but it gives very desired results even with the toric Sulcoflex.
The cost of the lens actually depends upon the power that -5 to +5, it is little less than the other power. And then another advantage of the Sulcoflex lens, it comes with the with the toric platform. So if you want to correct the cylinder, that also can be corrected by the secondary procedure.
Vasavada, sir.
Partha, before you came, we had decided that 4-minute discussion, and each of these office bearers on the dais will have by turn in addition to your comment in 4 minutes. So I think the next turn is yours anyway. So you be concentrate on the next talk by the Malik. You are supposed to be kind of commenting, questioning, and you're a moderator anyway.
Sure.
So
Dr. Malik is here.
Professor Malik, please.
If he's here, then
Dr. Hari, Rohit Om Prakash here.
Yes, Rohit is here.
Yeah, I'm definitely there.
Rohit, go ahead, please.
Thank you, sir.
8 minutes presentation and 3 minutes plus discussion.
Well, thank you, Dr. Abhay, sir, and Dr. Chairman, Scientific Committee, Dr. Partha, for the opportunity. So I would be reporting my worst case scenario, and as has been talked, I've been asked to talk about Rex's runaway. So they say when complications come, they come in crops, and they did so in my case also. The first case was an apprehensive patient who had been totally confined indoors because of COVID environment. So as we have been seeing, there's a spurt of mature cataracts. A very tensed up patient, capsulorhexis initiated, and as things would have it, I could sense that things are not working under my control, and as to my surprise, I found that it had extended. You can see the he's squeezing eye. The first thing which I did was I moved it around and I saw that the flap was fluttering. So I was going to use my flap motility sign to advantage. Then I put in my probe and saw that the flaps were everted and fluttering. That gave me an assurance that it was pre-equatorial and it had not become a wraparound tear. So I continued with my process. I was using a low IOP of around 40. I was evaluating and I was not pushing the nucleus by any means. I was I wanted to have stable chamber settings as well when I was continuing. The separational forces were in the axis of the tear, so it was not putting much stress on the tear and making it extend. I was rotating it and not rotating it beyond it. And while chopping, the separational forces were not quite extensive in this case. I just continued, and my idea was to pull it into the anterior chamber. And at the same time, I was observing that the flap was everted and it was fluttering. So I knew that the flap was continuing to be pre-equatorial for that matter. So again, I put it up
25
out, and I
it will get
continued
cool very fast.
and you can find that the flaps were still everted and fluttering. And I was using slow motion phaco for that matter. Interior chamber, since the nuclear pieces were not that hard because it was an intumescent cataract which was slightly brownish. At this, I was continuing with slow motion phaco, and the flaps were still fluttering at that point of time. Now, when I took it out, I maintained the anterior chamber, put in visco so that there was no sudden shallowing of the anterior chamber, and the chamber was maintained and before I took out the phaco probe. IA I started, and you can still see that the flap was fluttering and it was everted. So it was pre-equatorial by all means. Then I realized that the capsulorhexis at this point of time was not adequate. So I decided that why should I should put the intraocular lens, make things happen. Sorry. I should put the intraocular lens, and then after that, I decided to enlarge the rhexis. And you can find now that I'm enlarging the rhexis so that I can go subincisional because I don't use a bimanual. So I'm used to using a coaxial one. So taking advantage of enlarging the rhexis, I continued, and I was able to do, you can still find that the flap is everted and fluttering by all means. So I was rest assured that everything was perfectly fine. And while doing stromal hydration, you will find that still the flap is fluttering. So my idea was totally achieved. Next was a silicone eye filled one-eyed post-RK patient. So there were more than 16 cuts. So I made a scleral tunnel, and then I took out the silicone oil. The side port incision was slightly posterior and a guarded side port incision. Here I committed a mistake. I should have stained the anterior capsule, which I did not. And here you can see that it is extending to the periphery. I went in with the micro scissors because the other Vanna scissors was not working because of the scleral incision, and somehow I completed the rhexis. Once that was done, the next step was hydrodissection, which was a measured one, and it was not where the tear was. Once that was done, now I continued with the phacoemulsification. I put it on at a higher speed because of paucity of time. You will find that I will not move my phaco tip. I will try to keep it right in the middle so that I'm not putting any stress on the radial cuts. So the scleral incision is also happening, and keeping everything, the phaco probe in the center also helped me at this point of time. So the next point was, once that was done, I wanted to take care of the posterior capsule, the cortex. When I was going around with the cortex, I could find that I was not able to do it. And there was a sheet which was so much adherent that my going very much to the periphery, and I did not want to go put more vacuum because the surgery had already been done, and I didn't want to put stress on the zonules. I did that, squirting of fluid with a 5 cc, and I could not create an opening. So I went on the polish mode and did the aspiration. You will find that the vacuum in all situation is not above 75 or 100. I created a plane and I did all the, you will find all the way that the flap is fluttering. So this fluttering flap meant that it was pre-equatorial. So all the way I continued and I did polishing and aspiration of the sheet which was there on the posterior capsule, and I continued with the process. All the time I noted, you can see that the flap would flutter off and on, indicating that it is pre-equatorial. So flap motility sign in these patients, wherein there is a anterior capsular tear, helps us to ascertain whether it is pre-equatorial, and you can continue. The moment it stops fluttering, that is the time it shows that it has extended onto the posterior capsule. You should stop and convert. So you can still find that it is moving. So I continued with the process and I was able to take care of the sheet on the posterior capsule, which was there. And once that was done, the job was practically done here. Then the Iol was implanted. You can still find that the flap is fluttering. So friends, using the flap motility sign, even the worst days cannot become worse, because you know where you are, and with conviction, you can continue with the surgery and have the end result. So I applied a suture and the surgery ended. If the plan doesn't work, change the plan, but never the goal. Thank you very much for your kind attention.
Lovely. Partha?
Yes, sir.
Yes, go ahead.
Yes, thank you very much, Dr. Rohit. It was two very, very, very nice cases. If I can come to the second case first, it was exquisitely shown that how the flap motility sign helps us, and you've done a great job. You've taught us how to decipher the flap motility sign. My one concern that I would like to ask is, this was a silicon-filled eye. So how would you calculate the accurate biometric calculation of such an eye? Because with the silicon-filled eye, the accuracy is definitely not there. However, understanding that the macula also is compromised, so it's an eye that is not going to give very good vision. But still, the biometric calculation, which to my mind will come, and you can please give your comments on this, that what I would like to do in such a case is leave the patient aphakic, take out the silicone oil, let it settle, because again, this is an eye with arcane incisions. Let it settle, do a proper biometry once it settles, and then put a secondary IOL in the sulcus. This would be my thought on it, because of the difficulty of doing accurate biometry because of the arcane incisions and the silicone fill of the eye. So what would be your thoughts?
I fully take your comments, what you are saying. That should be, and that would have been the ideal situation. The patient was one-eyed. He was already apprehensive. So for him, we had already explained the prognosis that he may end up with some refractive surprise. But we did the Trokar, Barrett's formula in this for the post-RKI with the silicone filled, and hope for the best.
Thank you. I think we need to move on. We are a little bit, otherwise we'll be unfair to the last speaker. Is Professor Malik here, please?
I don't think sir has joined.
No, Maipal or Haripriya?
Haripriya is here.
Haripriya,
Yes, sir.
please make a presentation.
I think someone has
8
shared
minutes.
their
8 minutes.
someone's shared the screen, sir.
Dr. Harban shared the screen name.
Okay, so I'll go after him.
Okay. So,
Partha, if you agree, we may cut down on the discussion because we will be short of time at the way we are going.
sure, sir. So this is Harban's Lal, sir?
Yeah.
Okay, sir, continue, sir.
So I'll be talking about the PC rent, and I'll be showing two cases. In one of the cases, I was lucky to manage. So in this case, I removed the chopper. My settings are very high, but you see that I'm doing the phacoemulsification in the peripheral part, and you can see the small PCRM taking place. So when I tried to lift and remove it out of the rexus margin, because this part was sub-incisional and it is very difficult to collapse, and you watch that my rent gets extended. So now I put on a viscoelastic, and when I try to put on a viscoelastic, it causes the further extension of the rent. So now my first job was to really bring it out of the capsular rexus fornicis and secure it into the anterior chamber in front of the iris. So I was able to collapse it, bring it forward. Now it is secured, and I'm relaxed that it is not going to drop down. And because these hard cataracts do not have so much of a epinuclear plate and cortex, so the main management remains with the removal of this nucleus fragment. So I enlarged the incision to 4 millimeter in size, and I use my own technique, what I call as a chopstick technique. And usually I avoid doing phaco in presence of the PCR, because I feel that there are chances of further extension of the tear and this nucleus may drop down. So with the nearly 4 millimeter incision, with the two instruments, I tried to pull it out. Probably it needed a little bigger incision, it would have come out in toto, but there is no problem. I crushed it and slowly removed it. This technique is very good in the sense that the chamber is always maintained. We do not press on the lip so that the vitreous will not come forward. And these are the least bulky instruments. And mechanically, slowly we remove this part. And after removing a reasonable amount of this, you can inject further viscoelastic. And I thought, okay, now reasonable amount of this nucleus has been broken and removed. And now the pieces have become a little smaller. So I was worried that the small chunk may drop down. So I pushed it onto the one side. And then I went for the IOL scaffold, placed the lens on front of the iris, and then went behind the iris into the sulcus. Then we placed the trailing loop and dialed it, because now this is also placed in the sulcus. You can see a little bit of bleeding over there. And again, I usually avoid doing phacoemulsification in these cases. By any chance, there is a vitreous is there which you may pull, and then I again remove it again by my same technique, manually, by the two instruments holding it and pulling it out. Once this was done, to be 100% sure that there is no vitreous, I did the remaining removal of the viscoelastic, cortex, and blood clot, everything by the vitrectomy cutter, because if anytime you feel that there may be a vitreous, you can actually do the vitrectomy. So this clot was removed, and once this clot is removed, all the viscoelastic is removed. And before I withdraw my irrigation port, in all cases, even in routine cases, I do not allow the chamber to collapse at any stage, particularly in presence of the PCR. It is absolutely mandatory. I do the optic capture, because the capsular axis was of reasonably good size of 5 millimeter. Once the optic capture is achieved, I inject the air before withdrawing the irrigation port, and before leaving, I put on a diluted tricord to ensure that there is no vitreous, and the wound was properly sealed to make sure it's not leaking. Now I showed next case, which was really, I was not fortunate. I was called in the middle of the surgery, and you can see the trench was not deep enough. I tried to deepen the trench. Iris was a little floppy. The pterygium head was already removed. And when we tried to divide the nucleus into two, we could not break it into two. The central part is attached, but the peripheral part is separated. So I go and try to chop it, and you can see the grip is very superficial, so I could not actually create a crack. And meanwhile, the iris has started collapsing, and the pupil has started becoming smaller and smaller. And once we went in, pulled the iris in from the side port, never pushed the iris from the same port from where it is collapsing, but still there was enough of iris damage. We put the amalgam ring, tried to separate it further, but this amalgam ring was not so good, because it was already ETO, probably had less strength than what we needed to have it a full dilatation. So we plan that both the ends are well separated, only central part is attached. So we thought if we can remove on the both the ends half of this segment, we'll be able to handle the central part afterwards. So with the high vacuum setting, we try to separate and chop. So one piece we could take out easily. We kept on crushing and kept on removing it. And as you can see, my parameter settings were quite high. Vacuum 36 cc and vacuum setting of 600 I was using. And while I was feeling that's going on absolutely okay, one piece we could remove. Then we went on to remove the another piece. And here the reflex is a little too bright for the comfort. And the nucleus mobility was also not so good. And one stall has come out of the amalgam ring. And my suspicion was all right that the patient has developed the PCR. So now with such a huge nucleus inside and the amalgam ring one is stall out, and people already iris damaged to some extent. So I had no choice. Now you can see that there is a vitreous coming from the side port incision. So the another option was that we drop this nucleus into the vitreous cavity and put the lens, let the posterior segment surgeon manage it. So I tried to bring this huge nucleus out of the rexus margin and trying to pull it out. And with some effort, the central bridging fibers helped us in that. We could lift it. And once it was lifted, we enlarged the incision to nearly 7 millimeter or so, 6-7 millimeter. And again, I use my same technique of putting out with the two instruments. And we inject the viscoelastic once again. And by this time, we were not sure about what is the status of the capsule. And finally we did the vitrectomy. And you can see there's a lot of iris damage. So we closed the wound and left it as such and did the secondary IOL implantation after 2 weeks. So this was the worst case I have handled for a long time, where in spite of all the efforts, we could not put the IOL in the primary case. Thank you for the opportunity.
Thank you. I think we will keep the discussion a little later, but one sentence that I think the cataract surgeon should now, time has come to learn pars plana vitrectomy with irrigation in front or irrigation in back. And you know, you manage it very well, but for average, I think let's start accepting this principle. So I think let's move on now to
Mahipal may be little, Dr. Abhay, Mahipal may be little late actually, so you can go to the next.
Yeah,
one.
but the thing, yeah, Haripriya.
Yeah.
Yes, sir.
Please, Haripriya.
So I'll just be sharing one case. Is my screen visible?
Yes, yes.
I'll just be sharing a 5-minute video of a patient who had an opacified IOL. So this is a hydrophilic acrylic IOL. The patient had 618 vision, unhappy with the quality of vision. So the plan was to do an IOL exchange. As it's obvious, it's adherent very strongly to the bag. And here I was trying to just cut the bag. And what happens is, unfortunately, as I'm trying to cut the capsular bag, I kind of cut the cornea as well. So this was a big shock because the 15-degree blade was used to try to separate the capsular bag, but I extended the corneal wound, which makes things very difficult now. So I have made things worse for the patient. So I continue to go ahead and try to remove the lens. So I'm using a 1-hour scissors to cut the IOL. It's a hydrophilic IOL, so it cuts quite easily. A Sinskey hook is used, and using a bimanual technique, the IOL is slowly prolapsed using 2 instruments into the anterior chamber. So this is like a freak accident, trying to opening up the corneal wound when I'm here trying to explant a lens through a 2.8 millimeter incision. The patient has 618 to begin with, but I'm now concerned in my mind. I'm thinking, can I even give him that vision back at this stage? So I'm implanting a 3-piece acrylic IOL. I intend to do an iris fixation here. So normally with the iris fixation, we place the IOL butterfly style if you're using a foldable lens. This is a modified technique which I have now been using, but I place the IOL in the anterior chamber first, and then dial the leading haptic behind the iris. And before I take the trailing haptic in, I would like to capture the optic. To do that, the IOL is supported from below with a non-dominant hand using a Coughlin's hook or a cyclodialysis spatula. And once it is captured, the trailing haptic is then held and released behind the iris. So this technique ensures you have a optic capture. So this technique seems to be working well for me now. So with this optic capture, then I go ahead and then do an iris fixation. So the IOL is stable now, though there is no capsular support. I'm using a 10-proline suture. 10-proline actually seems to work quite well for iris fixation. We've been doing for many years now. With a long curved needle. This is the Oralab suture, but other companies work well as well. So I take the bite, including the iris and the haptic, and then the suture is retracted from the anterior chamber through the side. So using a Coughlin's hook here, there's no side port required. The incision is right above the bite. So I am retracting both the suture ends through the main tunnel and tying a couple of knots to secure the haptic to the posterior side of the iris. So at least 6 to 7 knots would be good. And again, not to tie it too tight because we don't want the iris to crumple in that space. So the second haptic is also secured. So again, a bite is taken. It is because of the optic capture, the haptic position becomes more prominent. It is lifted. So it's fairly easy to take the bite. So once the bite is taken, the optic is retroprolapsed to behind the iris. And then similarly, the second haptic is secured as well. Here a side port has been created over this iris bite and multiple sutures are placed. And then finally, I then go ahead and close the corneal incision. So these bites are placed more towards the end because the wound is now larger, having enlarged the incision inadvertently. And very careful because the iris, the corneal tissue here is very friable. Multiple sutures are being placed. And all the time I'm kicking myself, how could I go and mess up a wound? It's one thing to have a wound burn, which we don't see now again with all the new machines, but to go up and open up a tunnel is something which is very difficult to accept. So finally, the viscoelastic is aspirated out with a Simcoe cannula, so I have more controlled aspiration. However, of course, our friend the vitreous tends to prolapse, and then a bimanual anterior vitrectomy is done. This is just to show, that this patient thankfully did well. The IOL was stable post-op, and we removed the sutures after 2 months. And thankfully, the patient did very well. Our final outcome was good. Thank you, sir.
Thank you, Haripriya. Wonderful. You showed one option of iris fixation, but we now know, and you've done many scleral fixations and other fixations, but 10-proline is something I question now, because Oralab makes wonderful 9-proline if you want to use proline at all. But I think time has come to shift to intrascleral fixation, which Amar has been talking about for years. And I think everybody now is accepting that intrascleral fixation has a lot of advantages. But suturing, I've done enough on a scleral fixation with Gore-Tex or 9-proline, but suture is different than intrascleral fixation. But this case was really very good. And did you do vitrectomy here?
Yes, sir. I did it finally. Yeah, but I also, my primary technique of choice is iris fixation even now. I've been doing it for the last 15 years and we're having very good results. So with the scleral fixation, I find even the 9-proline doesn't work. But with the iris fixation, with the 10-proline, I don't see an issue with the iris, the suture giving way, even after many years. So I continue to use the 10 for the iris fixation.
Yeah, I believe you. You're one of the best. But for suturing, I've discovered that for scleral fixation, Gore-Tex works very well, but it has its own problem. And basically suturing technique versus intrascleral are very different concepts. But your iris fixation is something I have no experience whatsoever. So iris claw lenses of late Professor Dr. Daldit Singh and Kiran and everybody is one, and your iris fixation. So I think the fact is that there are many options available, and the surgeon chooses as per their own comfort and confidence. I think we move on now to the next. Is Professor Malik here? No. I think Amar, would you please
Yep,
come in now?
I'm ready. I'll just share the screen, Abhay. I hope my video is there.
Yes.
Okay. So let's see this case. And first of all, I'd like to thank Abhay for inviting me for this lovely symposium of his. And you can see someone has implanted a PC IOL in the AC. I made my scleral flaps. What is my game plan? My game plan is, after the vitrectomy, which you see I'm doing, my game plan is to make the same IOL from the PC, from the AC into the PC. So I'm trying to do that. Remember, it's a one-piece, non-foldable IOL which has been implanted in the AC. I'm trying to do that, but look, it's not happening. So I thought, let me make my side port incision. And Haripriya, you showed some nice one showing cutting of the cornea with that knife. I'm even worse. You know, I cut the haptic with the knife. So don't worry if you blame yourself, okay? I'm much worse than in that, okay? So I'm showing that to you how the knife, which I wanted to make my incision, has gone and cut the haptic. Now I'm in a game situation where I have no other choice but to explant the IOL. Now, look what I'm trying to do. I'm using two hands and I'm trying to explant that IOL, haptic. It's just not coming. It's so firmly stuck. Imagine putting a PC IOL in the AC. This shows how wrong the technique would be. I'm trying with both hands. Now I know I'm stuck. So what am I going to do? I have no other choice but to use a vitrectomy probe. So I'm taking my vitrectomy probe, and with that, I'm chewing up that iris. I know it's butchery, but I can't help it at this stage. Okay. So now you can see I'm chewing up the iris as much as possible so that that area gets removed. Now I use the handshake technique. Use two glued IOL forceps like a handshake and explant the broken haptic before it goes down. Now I still have the remaining haptic and the optic. So again, I use the handshake technique and explant the IOL. So far, so good. I've removed that IOL. Now I go in with the glued IOL technique, and you all know this very well, but I already have a large incision, so I might well use it like a non-foldable IOL. So I implant the first haptic, handshake technique, second haptic is out. Notice carefully how much haptic is out now. This is a key step in intrascleral haptic fixation. You need to have a lot of haptic outside, so don't go very posterior. Then tuck the haptics in the 26 gauge Chariot's pocket. Now watch, I have created a bad iris defect. So I'm using the single pass 4th row pupilloplasty. And you can see now with one needle, it doesn't need a paracentesis on the side of the needle where it's going in straight. You need a paracentesis only on the side where the loop is going to come out. From the other side, I've taken a 30 gauge needle through the paracentesis. Again, remember the number 4, single pass, 4th row pupilloplasty, and that is game, set, and match. So far, so good. I've done one. Now I'm going to do it because I need to make it smaller. So I'm making it my second portion there now. And you can see now my second single pass 4th row pupilloplasty done. But the superior is still problematic to me. So now I'm going to make my third one there. Now, watch now my problem. Now what we have is we have created an iridylase ourselves. So we started this new technique, which is a modification of Michael Snyder's hangback technique. It is called the Trokar assisted hangback technique. The problem in the hangback technique is you are at 6 o'clock position going up to 12 o'clock position with a double arm suture. Invariably, I can tell you, you'll get stuck with the corneal fibers getting into the needle. So what we decided to do is, I started this thing and it's got published also in the EJO. We passed a Trokar. Once the Trokar is in the eye, I pass this double arm needle. See, it goes out, comes out like this. And I use that Orolab suture, Haripriya, which is just fantastic. Double arm proline suture there. It's 9-0. Once one loop comes out, Here you can see I'm passing the second one. Now, all you need to do is pull, and that is over. Suture it, and it's done. So now look, wherever the iridodialysis is, pass your trocar exactly 180 degrees away from that. Now look, I'm going to take the double-armed proline needle, pass it through the trocar. Now it goes easily. One more advantage I tell you about the trocar-assisted hangback technique is, if the needle is single, it's very tough. It moves a lot. With the trocar, it gets guided very easily. So now once you have done that, I go through the iris. From the other side, I take a 30 gauge needle, as I showed you in the animation, goes through sclera, railroad the two, bring it out. Once that is out, now same thing I will be doing on with the other arm of the proline needle. So here you can see one has come out. Now I'm going to take the second arm. Remember, fluid is always on. If you notice, my trocar infusion cannula is always on. So fluid is always in the eye. There is no chance of the chamber collapsing. Now you can see it's pulled up that side. All I need to do is suture it and bury it. But when you pull this up, see what has happened. The iris goes up. So then you do the two-fold technique. That means you combine this again with a fourth row pupillasty and make that pupil back to normal. So here you can see now, I'm again doing the fourth row pupillasty, making that pupil back to normal. Now look at the one on the top superiorly. There's a huge iridodialysis there. So I have to solve that iridodialysis. And this is what I was telling you about. If you do a simple hangback without a trocar, I tell you from 6 o'clock to 12 o'clock to reach, it's very tough. With the trocar, the game becomes extremely easy. You can see that trocar helps the guidance of the needle, which was a great shock to me and a good surprise to me also. So I just go in like this here. And once you start this trocar assisted handback technique, I tell you what, you will start enjoying it because it makes life very easy, especially in these iridodialysis. Here you can see I've used the 30 gauge needle, railroaded it, brought it out. Now I bring the other one, goes through the iris, brings it out. Now the next step which I want to show you is the Purkinje image. The game plan is I need to focus my Purkinje image on the pupil. That is the key factor here. So you can see now it is bang centered on the pupil. Once I have done that, then I know I should be okay. So now you see we have the glued in place. We have the iridodialysis repaired. We have the fourth row pupillasty done. All I need to do is seal everything down with glue and complete the case. Okay, so that basically completes that particular presentation, which I wanted to show you about on this, one of the longest days which we had. Abhay?
You're very good, Amar. You showed so many of your innovations, and all of these innovations are, some of them slowly but surely are getting recognized all over the world. So, you showed it extremely well. But I think we will discuss at the end because I'm not sure the other speakers are coming, and if they come, we will be stuck with the time. But please stay. I want to discuss your case in Harbans. And is Partha here? I'm not sure whether he's still here. But now we have two speakers left, KPS Malik sir and Maipal Sachdev. Are they here?
Don't see them.
I'll call them Maipal, I think.
I think you will be better because otherwise we can continue discussing the cases that
we can start the discussion, I think, meanwhile.
Now I think we can, first let's discuss the PCR case and then the Iol fixation of various options at which we had wonderful presentation from Haripriya, and then Amar showed his cases and few tricks of that. So PCR management. Yes, lady, is the other two speakers here?
I am just checking, but I think they haven't joined us yet. They haven't.
Okay, thank you. Please let us know immediately, then we'll stop the discussion. Okay.
Sure.
PCR, any comments, Haripriya and Amar and Rohit, if you are still there, on the PCR? And Harbans managed it quite well, but there are issues and there are concerns. Each one of us has a different approach. So any comments from any of you, please? With the hard cataract dropping or get sinking into the vitreous. Hello?
Yeah, so I think when a hard cataract, once a PC rank is recognized, it's better to convert as early as possible, especially if most of your nucleus is intact. And to do that, I would prefer the SICS technique. Important not just to make a larger Am I audible?
Yes,
We can hear you well, yes.
One, I would abort that tunnel and create a large tunnel superiorly. The second thing would make a large capsular rhexis. So I would have to enlarge the existing rhexis, which was intended for phaco. And third, enlarge the pupil as well. Only after I do these three things would I think of prolapsing the lens into the anterior chamber. So that's what I would do. But again, if it has gone on the anterior, I think I would just have to refer the patient to the VR surgeon.
Okay. Amar?
I didn't see Harbans' presentation, but the question is simple. If you have a PCR with a nucleus fragment inside, I would do a scaffold. So basic principle is first do a vitrectomy, just bring the nucleus a little bit anteriorly, inject a 3-piece IOL into above the iris and finish the scaffold. After that, use iris hooks. Then you can use iris hooks, dilate the pupil so that you can go inside and see anything if you're missing like cortex, etc. like that, and then decide whether you have a sulcus or you can do a glued IOL or any intrascleral haptic fixation technique. That's what I would do if I have a thing. If it's a black cataract, I would convert straight away, like how Haripriya talked about. So this is the way. Third issue, if you have a sommering ring, because you might have a sommering ring in an aphakic patient or a case in which the iris is not there and also you don't have capsule, in which case if the fragment is there like a sommering ring, etc., I first do a glued IOL under that. Then I do the IOL as a scaffold. So that is the glued IOL scaffold technique.
I think you mentioned, which was not noticed perhaps by many of our attendees, that you do vitrectomy first before you scaffold. And
yeah,
that's
always.
very important.
I'm
not sure whether Harbans also used scaffold in his case, but I'm not sure whether he did vitrectomy before he put the scaffold. But that's a very important point that you need to keep in mind. Rohit, any other comments on it? PCR with dense cataract, Harbans showed it beautifully.
Yeah, absolutely. I think the key to it is IOL scaffold, if you can, or if you can take out the nucleus with the and converting to SICS is another option. If I'm permitted, I really would like to highlight, the Trokar assisted one. And this is a tremendous innovation. And I have used it in capsular bag fixations also. And I would be showing this video in OPL. And Dr. Amar, I would like you to compliment you about that, the Trokar assisted one, because that makes life so easy. The maneuverability, the cornea doesn't come in, and you can maneuver maybe by 30 or 40 degrees. And an average surgeon can look good, and it makes life so easy. And I think I would like to compliment you again for that.
Thank you, Rohit.
No, I think Trokar is a wonderful innovation. But coming back to the PCR and hard cataract or whatever, I have a little different philosophy on it. And I believe that our primary goal of a cataract surgeon is not to sort of stop lenses going back. Because at the end of the day, what we want to do is to have a list complication. And we really need a retinal surgeons if you're not exceptionally good in a vitreous surgery as a cataract surgeon primarily. So time has come to manage along with the retinal surgeon on the table if you can. If you cannot, do not get into the vitreous with the forceps or scaffold or whatever unless you really do a good pars plana vitrectomy, because our aim should be to prevent acute intraoperative retinal-vitreous traction. And putting all these instruments to fragment the nucleus or grab the nucleus fragment when the vitreous is in an anterior chamber, or passing the lens as a scaffold into the vitreous before you do pars plana vitrectomy is dangerous. So I think we should resist the idea that anyhow we should not allow the lens fragment to drop back. That is, I have done it for years and I realized that's a mistake. So our aim is not to stop that going in at any cost. Of course, we want to stop it. So please remember, vitrectomy is the very important step. And Amar said it, but I don't think, Amar, you need to do that more, emphasize more on that. I see many scaffolds getting into the vitreous first. The vitreous is there, and the first thing they do is to put a lens through that vitreous
Should never
giving
do
the
it.
traction to the everywhere, So I think that that's very, very important. That and your idea is terrific. So I think that's one. So I would go for a bye-bye technique, do a vitrectomy, whatever goes, either manage straight away or next day or whenever possible with money and our own people or whatever. So you don't feel ego issue about not managing everything yourself. Time has come to give the safe eye in general. So that's what I want to convey to the attendees, that if you cannot, the expert has shown it very well, but remember, you should be very proficient in understanding the anti-vitrectomy in any of these complicated scenarios. So,
Abhay, can I just add one thing? Because you said a very valid point. The point I'm making is once the nucleus fragments are in the anterior chamber, people are scared to do vitrectomy because it'll fall down, but it won't fall down because it's lying above the iris. So once you do a vitrectomy, then if you put the scaffold inside, you are safe, as you said correctly. Other than IOL going into vitreous directly is not the method.
That's what I see everywhere, actually. People doing.
What I was telling was, in the first case, there was no vitreous loss at all. Actually.
No, I'm not talking about your case. Harbans, you did great.
I had a question for Dr. Harbans. See, when the pupils started coming down, and you really had a lot of struggle dealing with the nucleus on the face of the closing pupil, could you have not used an iris hook or two iris hooks just to give you more access to the peripheral aspect of the nucleus to push it up, and then then continue the manipulations?
Actually, I think the Malvern ring works very well. Only thing was, this was probably Malvern ring which was ETO'd and probably used many more times, so it lost its strength and it was not holding on so well. And so that may be one reason. And I think Malvern ring works very well. Of course, iris hooks can hold it better. There is no doubt about it. Can give a more wider dilatation than the Malvern ring. You got a very valid point in that.
I agree with Arup. The retractors are great. Yeah, okay. Now, if there is no other comments or questions on PCR management, let's move on to the Iol fixation with no support and all this complicated scenario. And we had two examples of beautiful examples, well done, on iris fixation with sutures and then glued IOL and few other innovations in the pupilloplasty and the Trokar assisted. I hope the other speakers are not here. Otherwise, we move.
Dr. Maipal joined.
Oh, Maipal, hello.
Hi, hi.
Yeah, Maipal, get on because we are just waiting for you and discussing for you to come.
Yeah, sure.
Please go.
Thank you. Thank you, Abhay. Hi, Amar. Hi, everybody. Hi, Arup. Hi, Harbans. Hi, Haripriya.
Hi, sir.
Yeah. Hi, Rohit. Well, I'll be talking about a worst case scenario with femtolaser cataract surgery, and this is a case that is something that I love to do with a femto, and that is a posterior polar cataract. And we have Abhay here, who's also a master academician as regards posterior polar cataract and has described several techniques that are there. Now, the points that need to be kept in mind when you're doing a posterior polar cataract is to have a closed stable chamber that is there. When you're doing using the phacoemulsification, the fluidics need to be as low as possible. And what we are doing in the femto is the use of the anterior segment OCT, which helps you in delineating as to what you have to do. Also, the advantage of the femto is to give you a perfect CCC, which is going to be a boon if everything goes well, and it can be a savior if things go bad. The hydro procedures need to be looked at, and in a femto procedure, you really don't need to do a hydrodelineation or a dissection because there is a pneumodissection that has happened. And the most important thing is that we get this epinuclear cushion, which we have in these particular cases. Now, the anterior segment OCT is a high definition 360-degree anterior segment imaging, which delineates the anterior and the posterior corneal and lens borders. So just look here, you can see very easily this line is here and there is a defect that is being delineated. So what you can do in these particular cases is to customize your offsets. So when this is the normal lens anterior convexity, the posterior part of it, and you can see that there is no defect as here, but there is a defect defect which you can see in this particular case. So this is both posterior polar cataract diagnosed in the OPD, but you can see that there isn't a clear-cut difference or a defect which is here. So what you do in these is that normally the default is set at say 500 microns. So you will, under direct visualization, raise this default to see as to what you have to, where you have to do. Now, this has been described by several authors, including Chan and George Kimnos, and then also from Dr. Venkatesh et al., Pawan Kumar. This is that how can the OCT help you for demonstrating posterior capsular rents, and this is something that we need to use even pre-operatively, and with the newer generation of OCTs, you can possibly look at these defects at that particular time. But the documentation actually came of the efficiency when one looked at the femtolaser, and this is the article that was published in Journal of Cataract and Refractive Surgery. This is a photo essay that was there. And what we found in both of them was that you can easily diagnose whether you are likely to have a PCR during the procedure or not, that is there. So this is, you can see what I'll wish to show you is that very clearly when you look on this slit lamp, there is a defect which is there. You can see this, which you can see even pre-operatively. Now this is even when you're looking at an IOL Master 700, this can also show you, if you look discreetly, that there is a defect which can easily be seen here. And this is the intraoperative OCT which is showing you this rent, and see how clearly the vitreous bulge is coming here. And you can see that the vitreous hyaloid phase has not ruptured. And this is the pre-operative part of it, where you can see that this is the default which has been raised so that you are having this epinuclear cushion which is there with you. And this is again to show you that this is where the defect is. So this is something that you can easily see. Now let us see the video that I had in this particular case. This is the pre-operative part. You can see there is a clear-cut defect which is there. So we are mentally prepared that there is likely to be, or there will be, a posterior capsular rent, and irrespective of whatever you do. And you can see that we are looking at this particular point, and this is the area where there is a missing part. So we will increase the default settings here. You can see that this is the default settings which are going up. As we take the default setting, we have got this great epinuclear cushion which we will do. This is the capsular X's which we made for 5.2 so that the nuclear fragments can come. You can see that we have made 6 fragments, and this is again, there is no disturbance of the rent which we had seen. Now you can see even on this intra-op OCT that there is a clear rent which is coming. You can see here that there is a clear rent which is coming. And without doing any hydrodelineation or dissection, we have been able to remove the entire nucleus. Now again, you see here that the defect comes into view. You can see that this is the defect which comes into view. And we are doing a gentle irrigation aspiration. A bimanual irrigation aspiration can also be done. And you can see it is only at the end, without disturbing the hyaloid. You can see that we still have this. This is the bulge that is coming, but there is no breakage of the hyaloid phase. Now what I did in this particular case was that we should put in a 3-piece lens, but I put in a single-piece lens, and there was a slight jerk. And as you can see, as I pushed it in, you can see that the hyaloid has given way here. And when we are doing a hydro procedure and washing away the viscoelastic, just see that this is, I'm trying to put the lens in position, and suddenly, boom, the lens goes in, because there was a huge defect. So we should not be adventurous. You can see this is a tough case. What the hell has happened? I had finished everything. There was no vitreous loss. And this is the time that we are trying to do to get hold of the intraocular lens. It could, as Abhay was saying a little earlier, we could have made it fall down. And as Arup was saying, we have to lift up the iris because the iris has come down. Actually, we put in a little bit of a pilocarpine to bring down. And we are trying to do these manipulations to hold the lens. And it is a two-handed technique that we are trying to do to get the lens. And we are able to use 2 forceps and bring the lens into a secure position, just bring out the haptic. And in this particular case, I am taking out this particular lens because I want to put in a 3-piece lens. There is no way that I want to keep the a single piece, and this is again Harbans has shown this several times. You cut it up to the midpoint into half, and you can just roll it out through the incision. So now we have this problem sorted out that the lens didn't go in. We have to do a vitrectomy, which is there. Once we have to do the vitrectomy, we have to see, and I'm putting these 4 iris hooks to get a look at the capsulorhexis as to where the, so you can see a round, beautiful capsulorhexis. Whatever vitreous is there, again, we're doing a vitrectomy, and then we have paradise regained, as I will say, a 3-piece intraocular lens that has been put. So friends, all that I'm trying to say in this particular case is that the surgery is not over till it is actually over. And that is something that you have to see, that despite the power of femto, it was an error on our part thinking that everything is fine with such a huge defect, trying to go in with a single piece lens, which caused that it went in. So the advantages of the femto, as I will say, is it helps you prepare for the surgery. The incisions are perfect. You give a closed stable chamber. There is no fluctuation. You need to use fluid for doing a dissection, hydrodelineation that is there. And the safe thing that you have, what I told you, is this rhexis, which I use subsequently, well-centered rhexis. We can do a pupillary capture of the 3-piece intraocular lens that we do onto the capsule. And this is the blessing that we have with a femto, that we are able to go ahead and work on the nuclear softening and not do any rotation. The epinucleus gives you a great cushion. I can say this is like a shield that you have, and this acts throughout till the very end of the procedure, which is there. So friends, for me, a femto is like you are doing a phaco, you are driving a car. And in this particular case, you are driving a car with great airbags and the cushion support that is there. So you will be much safer, life would be saved, and you will be getting out with good results in the use of femto laser. But mind you, each step is critical, and be watchful till the very end of the surgery. So these are numbers. Abe has shown that the rate has gone down when he has switched over to flax from 36% to 4%. Osher has shown that the number, Titial has shown that the rates have gone down. So to sum up, posterior polar cataracts are a nightmare for even the most experienced of the surgeons, but the anterior segment OCT in femto lasers done even pre-operatively and intraoperatively will give you a good guide to how you have to do, and flax is the much needed safety cushion that is provided to you and is the way forward, I would say, in all posterior polar cataracts. Thank you very much for your kind attention.
Paul, very, very educative talk and videos that you shared with all of us, and we all have benefited from some of the tips that you shared. Femtosecond or flax appears to be very advantageous in particularly posterior polar management, whatever the technique of flax you have, there's no question about it. But those, and majority do not have flax, I would suggest that to perform some kind of a control manual delineation to create, and we found inside-out delineation useful, but whatever the manual technique of delineation, make sure you have a very slow and controlled delineation and not the subcapsular hydrodissection. So that's wonderful, wonderful. Any comments on the posterior polar? Yes, Harbans.
You are muted.
You're mute.
Did you try to inject the IOL straight away into the back? You first release on top of the anterior capsule and then try to?
It was actually released on top. I didn't try to inject. That would have been a folly, but I did not do that. But despite that, when I put the lens in at the time of the rotation, you could see that it was a huge defect. It just opened. So this was a lens which I normally do not use. This was a Bosch & Lomb aspheric, which just comes out with a little more jerk than if I had used maybe a Technis lens that I'm used to. And we could have done it in a more gentle way and put it perpendicular to the extension of the rent, because the intraop OCT was giving me great knowledge that there is the vitreous phase is still intact and the rent is there. So the problem is, yes, having a jerk would be a problem. The second is that if while rotation, what we have, and while hydrodissection, when the chamber actually ballooned up, and that's the time the PCR increased and it gave way. So I would still say that with such huge defects, which I did have a 3-piece lens. I don't know what came into me, and I said that let me try, because it's the vitreous phase is intact and we will have a stable lens. So it's always better to err on the side of caution, I would say.
Okay.
Yeah, sorry.
Yeah, Rohit.
Yeah.
Coming to
I think-
that way, Alcon lenses are the softest. They come with the least jerk actually, as compared to the Bosch and Longman Technis actually.
But I think in putting the lens, I would actually put the leading haptic in the bag, Harbans, not in the anterior chamber in front of the capsule, because the haptic optic junction of all the single piece hydrophobic lenses are difficult to bend and put the lens into the bag. So instead of two haptic optic junction pushing into the bag, I put leading haptic into the bag straight away. So I have to do only one thing. Still it ruptures. So single piece is something, it's not an easy lens to put in an open capsule.
No, I think Abhay, there is a bimanual technique of putting the haptic inside the bag. That means with a rounded deposit, you lift the capsule access margin up, and with the dumbbell dialer, you pull it and release it inside. So that way, I mean, instead of just trying to push it, so put from one side port, lift the access margin up, and with the another instrument, pull the haptic and guide it into the inside the bag.
I think three-piece is a good idea. You can capture three-piece through anterior capture X is also in case you fail to put it in the bag. So three-piece is the one which, as Mahipal said, he would have liked to put three-piece.
I think for general public, I think what they should bear in mind is that if the posterior capsule is not rounded, don't venture into putting the lens in the bag. That is the first thing. The second most important thing is what Dr. Mahipal has adequately shown is the epinuclear shield, That's a wonderful thing which we should not, pull it out, keep it there so that we are not exposing any fluidics to the open posterior capsule and hydrating the vitreous. The third thing which I would like to add is that whenever in a case of posterior polar cataract, I am doing stromal hydration, I constrict the pupil. Because when you constrict the pupil, then it doesn't, give chance for the fluid to go behind. So if you keep it as such, and I've seen that at times there's a PCR, even if it was not there till the end of the surgery. So when doing stromal hydration in the posterior polar cataract, if you can, just put intracameral pilocar, constrict so that the fluid doesn't have access behind the IOL.
Rohit, we had put pilocar in. The problem here is that when you are doing stromal hydration, the amount of fluid that you are pushing, you normally push it with a lot of pressure so that it goes into the stroma and hydrate. So I think that is something which can suddenly increase the pressure within the bag or push the posterior this thing. So that needs to be done gently, or maybe you could even leave it like that if you feel that it is secure.
Absolutely.
I think, Rohit, your point is correct. But I take a suture. I take a vicryl suture or 10 or nylon suture, even if it is 2.2 millimeter incision, if I have ruptured and I had a problem of vitrectomy and so on. But hydration and raising IOPs is not a good idea.
There is another thing. What I do is I take two swab sticks and press gently on both the wounds. And if you can have a patient for 1 minute, it automatically seals completely. Because the pressure is now from below, this pushes the valve up along the roof of the cornea. So we just keep it pressed there. If you have got a patient and count up to 100, and you will see that even the leaking wounds will close. Instead of keep on hydrating the stroma, it's better to put a pressure, let the wall of the corneal lip come up and get sealed over there.
Okay. Is Professor Malik here? Because he's still, we are waiting for him.
No, sir, I don't think sir is here.
Partha? Yeah.
Sir, he's not here.
So Partha, with your consent, let's discuss now the second section of the, which Amar and Haripriya showed, the Iol fixation options. And we had a beautiful iris fixation technique using Prolene sutures and then glued IOL and many other tricks of pupilloplasties and using Trokar to suture and railroad and dialysis and so on. So any comments on those areas? Unless you have something else to discuss, let's do that, which will be relevant to our audience here.
Yes, sir. So one thing that if I could make a comment on Dr. Haripriya's technique of suturing, I've seen her do this for nearly, I think, 10 years ago also. And I think, in fact, a patient of hers follows up at Calcutta, and we keep seeing the patient, and it's a very, very stable IOL after nearly, I think, 7 to 8 years. So this technique is a technique that is quite simple, needs to be learned, of course, but the fixation is very strong, and there is no reaction after such a fixation to the iris. The apprehension of that maybe there would be a post-operative reaction or a late reaction or a CME, I think in her series, she might give a comment on that. I don't think we have seen it.
Haripriya, I don't see her on the, I'm not sure whether she's here still. But I also have a concern of these iris fixation, of the lens stability. It's not really rock stable like intrascleral fixations of glued or Yamani or whatever. And the suture material degradation, particularly if you're using 10O proline, it is a concern to me. But Haripriya said she has seen over the years that it's fine with iris fixation. So, I'm sure she's right. Okay, now the Amar,
I'm here.
Yeah, Amar, your glued IOL technique has been a phenomenal change in the way we, the cataract surgeons, are managing now many cases of exchange IOLs and a grossly subluxated lenses and so on. And you made it very simple in many ways over the years of small little technical pearls on it. Do you want to add a final one which helps our people who are learning still glued IOL?
But
so
very
that
important trick is simple.
commonest problem they have.
Yeah,
and
I'll
how
tell
do
you
you
the
solve
commonest
it?
problem which anyone will have is the amount of haptic which is externalized. If you take a larger eye, let's say Marfan syndrome, these eyes are large, let's say 12 millimeters. So simple trick is, actually Samresh has made a very good video on how far behind you should make it, as you know it, and which I think it won in the film festival also. But coming to this topic is, do a small iridectomy in the area of the scleral flaps. Once I do a small iridectomy, I can come more anterior. When I come more anteriorly, I go through the iris, through the iridectomy. Then when you externalize the haptic, the amount of haptic is a lot. You will never have any dislocation. Even if you do Yamane, you'll notice some videos where people are doing Yamane and suddenly they've created an iridolisis. And the reason is very simple, because you can hit the iris. So if you come anteriorly a little bit, and then you might hit the iris. So just do a small iridectomy on either side, come anteriorly, you'll have enough haptic out, and that is over. One topic on iris suturing, I never do the iris suturing of the IOL, but Terry Kim has started doing the 4th row pupilloplasty for iris sutured IOLs. So he's presenting it in the OPL in the American Academy also. But just I thought those who are interested can try it out. I have never done it because I don't put iris sutured IOLs, but I'm just telling it to you. But as I feel, all these sutures, IOLs, they move.
Yes,
there is
I think we all recognize that. I have a question. Please explain why you think you want a longer haptics out and not the one that typically most of us do a kind of not so long. What is the advantage and why you're recommending that?
The reason is very simple, because when I've seen my post-ops, when we started off the system, I realized that sometimes if you don't have enough haptic tucked inside, you can get a post-operative dislocation. Okay. When we have started doing this like this, I don't get these dislocations, to be honest to you. And I'm talking of large eyes. I'm talking of even 12 millimeters, 13 millimeters eyes. I'm able to do nice amount of haptic intraocular fixation with this technique. So very simple trick. It's not so difficult. Just doing a small iridectomy in the area of the scleral flaps on either side, coming anteriorly, and you'll be bang on track.
So you are using a tunnel of 26 gauge needle.
Yes.
What would, if you do 27 or even small, will it slip again?
No, it will not slip. You can use a 27 gauge. I suddenly had a 26 gauge. I used it. That's all. If you have a 27 gauge, you can use a 27 gauge.
No. So if instead of taking long, which is not easy for
okay, no.
Can you solve that problem by taking a smaller tunnel?
Yeah, because if you have very less haptic tuck, you are living on chance. My question in life is, I don't want to leave anything to chance. You might succeed. I'm not saying no. Let's say out of 100 cases, 90 or 95 might go well. My question is, I want that perfection to go to the extreme level, where things go bang on track.
Okay. Any other comments on this area? Anybody here?
Amar, have you seen the presentation of Debian? What is your thought on the
Carlyle lens. See, Carlyle lens, just off record, but it's a webinar, so I don't want to talk too much on it. It's a good thing. The problem is, understand, you are bringing it out like a T.
Yes.
And then again, if you notice in that videos of Carlyle who brought out the lens, is the amount of haptic tuck again is a problem to me. Again, so when you have a 3-piece lens available in your hand, which is already available in the market, any company all the companies have it. Only thing I would like companies to make them 14 millimeters. I've tried to fight with all of them, the top bosses of all these companies, whether it is AMO or anyone, but they've not understood it, because I think the amount of expenditure for them to make from 13 to 14 millimeters is too much. But if you remember, Abhay, JCR has brought out a white paper. I think you must have been part of it also, if I'm not mistaken, where they said the lens should be 14 millimeters. That is the answer.
Yes. Okay. Now, is Rohit here?
Yes.
Yeah, your capsule motility sign has been a phenomenal educational tip for all of us. But I noticed that in your video, you were using a lot of high parameters of high bottle height and 40 cc flow rate or 50 cc flow rate. Would you think a slower flow rate and lower bottle would further add safety to your managing so well? Would you think it will improve?
Absolutely, it will. But the confidence on the flap motility sign and the surgical techniques like not vigorous movement, slow motion phaco, definitely takes up the case to go ahead smoothly. But definitely, as you said, low fluidics would definitely add another thing to the cherry.
Yeah. And Arup here.
Another, I think I would like to add one point. The capsulorhexis margin have to be defined in 2 ways. One is whether it is a conal or it is a curvilinear. So when you are doing a rhexis and it becomes curvilinear, the chances of going back are much less, because the direction is in a curved shape. So what if it is a straight conal cut, as in an intermittent cataract or mature cataract, the chances of running behind are far more higher. So whenever you're doing a young patient, when the rhexis goes out, which is in a curved shape, the chances of running behind are much less.
Absolutely.
Okay. Partha, would you be kind enough to sum it up the whole session now? We have 3 minutes or so.
Yes, sir. So thank you very much, everyone, chairpersons, Dr. Baswada sir, Haripriya, Dr. KPS Malik sir, we have missed, unfortunately, Harbanslal sir, and we have had a very, very nice session with the difficulties of biometry by Arup. It was a lot of learning for the biometric difficulties, and these are aspects that go on to a learning for the next year. With the worst case scenario that Rohit showed, it was very nice, and thank you for all those extra pearls that you came up with, Rohit. And Harbanslal sir, of course, the PC rent is a video that has to be seen by everyone, and everyone, whoever sees it, learns a little more. Maybe the scaffold technique also, which Amar again has propounded, is a very good technique and can be emulated. And it is a very safe technique for most of our surgeons. My pulsars, of course, the discourse was excellent, and even with the femtosecond laser, the problems that can occur so well enunciated. I think that was all. Yes, I think. And of course, Haripriya's talk on the fixations of the IOL and the explantation was a very important talk. These with what showed up is, even for a very experienced surgeon like Dr. Haripriya, even these catastrophic corneal slits can occur. It has occurred to me just about 15 days ago as well. So these are happenings that even the best of surgeons can have, and it's a learning all the time. Thank you very much, sir. Any last comments from yourself, sir?
I think it's, I have learned, and I'm sure we all have learned, and attendees would also have benefited from the experts' very honest and generosity that they've shared their really difficult conundrums here. So I think, thank you all for your honesty and sharing and education to all of us. So have a safe time and a good evening. Thank you so very much.
And we have finished.
Thank you, everybody. Bye-bye.
Thank you. Thank you.
Okay.
And Harbans, all the very best.
Thank you. Thank you. Thank you.
Half an hour more, Harbans.
Yes. Okay,
Just,
bye.
I think 35 minutes to go, my pal. No?
Bye-bye. Bye.
Bye-bye, sir.
Thank you, everyone. Thank you for joining us for this session. It was a very insightful session, and yes, we winded up on time. So this was the last session of the day. Thank you so much for joining AIODC for this conference. Thank you so much to all the panelists of this session.